Ooh.
So, without further ado, it's my great pleasure to welcome you all today and to this session organized by the European Health Futures Forum on designing the future and when we're using our skills on moving towards that future to really use our good thinking and design skills to create that future. With me today, I am your host, Lars Münter, the Development Director for the EHFF, but also with me today, I have three esteemed speakers, Daniel Steenstra, Dina von Heimburg, and Mickael Bech. We'll be trying to go through three different rounds of talking about these issues, and Daniel, Dina, and Mickael will be trying to share some of the insights that they have from their research and work. Um, but first off, we'll be talking in a short intro round for these individual speakers. So if you'll allow me to put the spotlight on you, Daniel, first as a first intro, and afterwards we'll be diving into some of those insights first. But let us hear, Daniel, please, a short description of who you are and what brings you to this future.
I was looking around for the spotlight actually, but anyway, I'll make this really, really short. I'm actually, strangely enough, on a boatyard in the heel of Italy. I actually live in the Netherlands, and to start off at the beginning, for me, it's always been about quality of life or trying to make a contribution towards quality of life of others. At first, I chose a career in medicine, became a doctor, and after 2 years, I noticed it had a huge impact on my own quality of life, which went down, and the quality of life on patients was very difficult to find. So then I became a car designer. So my quality of life went a lot better. I designed Ferraris and Jaguars, but you could argue that it's a very limited of audience whose lives are impacted. Then Jaguar owners are still dear to my heart, but that's not really the audience that is of interest to us. Then 25 years in lecturing, basically in the UK. So I spent 30 years uh, of my career in the UK. Most of that, well, doing several things, but including lecturing on design and product development, and sort of circling back into healthcare. So, for about 10 years, I was also the Royal Academy of Engineering's visiting professor in medical innovation, and I did a lot of my research in trying to understand why health innovation was so challenging, and particularly did some research on understanding why disruptive innovation was failing. So that's me. I'm very keen to hear others. Thank you.
Well, thank you. Um, Not the most common career trajectory, but I suppose that's true for a lot of people in this room. But moving forward then to you, Dina, if you allow me, please,
Yeah,
what brings you to this future?
thank you, Lars, and thank you for the invitation to participate here with you. So my name is Dina von Heimburg, and I work as an associate professor at the Norwegian University of Science and Technology in Trondheim, in Norway, and at the Department of Education and Lifelong Learning, where we have a Nordic Research Center on well-being and social sustainability that we call welfare. In my previous careers, I'm trained as a nurse, and for many years I worked as a public health coordinator in the municipal settings, and I've also been working a lot with the WHO in the Healthy Cities network, and also currently also doing some work for the WHO on the wellbeing economy. So that's me in short. Yeah, thanks.
Well, also quite a well, not the most obvious career path either. Mickael, can you also maybe sort of share something similar of a trajectory? Oh, sorry, that was Marianne. I'll go back to Mickael.
I'm sorry.
Spotlight
No,
here.
no, I'm not sure I can present anything on car design or nothing like that. But I was trained as an economist and has been working as a health economist professor for many years. Now I'm professor in healthcare leadership and policy, and study doctors and their leadership, but also various reorganization of healthcare, and sort of more recently also been involved in commissions that have proposed changes for the Danish healthcare sector, and now it's about to be implemented in different types of healthcare reforms. So that's me, my career.
So interesting also. The purpose of the first part of our session here is to look into, Daniel, some of the essential goals and focus points then. And I'm not sure necessarily when we're talking about health transformation that there's a direct line from the Ferraris to our current healthcare system. But please, some of the essential goals and focus points that you've made from those experiences that we should consider on how to do transformation in health.
Fantastic. So the first thing to say is really, I'm pleased to see some familiar faces and new faces. Mickael in particular makes me a little bit nervous of the next slide I'm going to show now, because this is a conceptual slide that I've used for many, many years, but I cannot find an empirical data to back this up. But I think we're all aware of this. There's a huge gap in healthcare between the increasing demand, all sorts of factors, aging populations and so on, and the capacity, the supply that we as healthcare professionals and so on can actually give to people in need. And so as I said, I've used this slide for many years. I can't find anybody, any institution that gives some real data behind this, but I hope you can sort of feel that this is reality. Obviously, on the horizontal there's time, and on the vertical is healthcare delivery, whatever unit you sort of use for that. But this is a recent addition, because I think there's a third dimension, and it's an important dimension. USA, as you know, is off the scale anyway. That nation is spending more of its GDP than any other country, and yet the gap between people that have healthcare access and don't is bigger than anywhere else. But what I really want to talk about is the UK, because the NHS in the UK is the biggest healthcare organization in the world, period. And to me, that makes it a little bit like the fruit fly for biologists. You can see by studying the NHS, you can see trends. What's might happen to other health nations, and maybe the country where I'm living now. So I said I spent 30 years living up to a point quite happily in the UK until Brexit, obviously. When I got back to the Netherlands, and I was trained as a doctor in the Netherlands. So if you're in the Netherlands and in Denmark, you might be at the beginning of this gap. You might think, well, why should we transform? Transformation is really, really hard. We can just tinker with what we got. We can do, a bit of improvement, a bit of lean, and we will be okay. My argument is look ahead. My argument is look at the UK, understand what's happening there, and seeing that this is your future unless you transform, basically. So that's the argument I'm trying to make here. So every system, I think, is on this trajectory. And what we've done at EHFF, by the by, and I'll come back to that hopefully later on, is try and study what transformation would actually look like. What can we do? What can we see? What can we do? What sort of things do we need to promote, push, coordinate, and so on, to really bring this gap to a close this gap, bring the supply and demand in line, which is hugely ambitious, obviously. I think the key word on this slide is trust, really. We got traditional hierarchies, and we probably recognize that doctors and nurses and other healthcare professionals work in very traditional systems. We're even educated in paternalistic, maternalistic, systems and so on. And that's not the way of the future. Communities actually are organized in a completely different way. And I need to go back to 2008. I just thought about it again. 2008, a banking crisis. Our government, on our behalf, decided it was a good idea to use our taxpayers' money to bail out the gambling bankers, and that drove austerity, and you can see, I think, a lack of trust building up since 2008. COVID was another point where we can see where we could only trust our next door neighbor to look after us when it came to it. Our government was sitting on their hands. So there's a trust is a big thing, and it's sort of going or indeed gone. So that's what this slide is showing. I only recently came to this, and it seems obvious in retrospect. You cannot transform without innovation. You cannot innovate without design thinking. Leadership, design thinking needs leadership, and leadership needs the right culture. And what this is also almost an atomic model. As you might remember from chemistry classes, where atoms are built molecules are built of atoms, and atoms have electrons and they move around. And that's what this is showing as well. Culture is not static, it moves. Leadership is not static, it moves. Design thinking is not, it all moves, but it needs to be inherently connected. These 5 elements need to be deeply aligned for a system to work, and indeed for a system to transform too. And if you then say, okay, look at some initiatives that have failed, you can use this as a diagnostic. It's probably failed because there was no design thinking, or the leadership was disconnected from innovation, or the culture of the organization was sabotaging change instead of supporting it, and so on. So there's more, I think, we can explore and talk maybe about around this model. This was the brief. 3 essential goals is obviously, if you talk about transformation, it's about multidimensional change. It's not just a little bit of process improvement. It's actually understanding there's at least 5 dimensions, and the change needs to happen simultaneously in each of these 5 dimensions. And what we've done at EHFF, just to give a little bit of quick background, during COVID, we were in the fortunate opportunity to use the 3 Horizons model to really understand why we were in the situation we were in, and that's Horizon 1. I still find it very scary and very telling that a bunch of experts in going through this model actually came to the conclusion that we're in the situation we're in because there is no shared vision for health, period. And I, as a designer, I find that scary. How can you plan towards the future if you don't have a vision? Horizon 3 is then about a vision, and this vision is about seeing health in the context of the whole planet and so on. A key role, I'm pleased to see Christine, but I would have mentioned it anyway, is obviously health literacy. And what we spent a long time on is Horizon 2. So how can we bridge that? How can we go from this reality we're in now to the future reality? And we did a lot of work there on understanding in theory and mapping out in practice the activities that need to happen on Horizon 2. But I think I'll stop here, and hopefully we can get back and discuss with the others on some of the points here. So it's about multidimensional change, it's about simultaneous alignment, and it's about moving from talking to doing and proving things out. Thank you.
Thank you so much, Daniel. And lo and behold, instead we'll see Mickael. It seems that Daniel has both an urgent request to get good data from you potentially, but please, Mickael, share some of the essential goals and focus points in transformation from your perspective.
Good, thank you, and thank you very much, Daniel, for that introduction. I think the sort of double demographic pressure that you showed, the two graphs that are becoming an even a huger gap, not only now but in the future. I think not only has to do with need, but also expectations. As I mean, since we get richer, we also have higher expectations, and that one of the reasons for the increasing gap that we see between capacity and what we demand from healthcare systems. And I think one of the sort of first starting point for me is that transformation is not necessarily the same as optimization. And the reason why I say that is that we have to think more deeply about what we want to do or what we want to achieve. Because I think at the moment, a lot of the things where we have been doing is to optimize healthcare system to deliver more, but more of the same things. And we have to stop doing that in order to reduce the gap that Daniel has been talking about. Because if we just sort of tweak the current system and try to optimize the current system, I don't think we'll have any chance of reducing the gap. We, in a sense, have to rethink services, the way that we deliver services, and in a sense, what we consider to be healthcare systems in order to succeed. And in a sense, we have to go from a very specialized and but also very fragmented healthcare system to much more a system that talks about ecosystems, talk about system perspectives, and some of the things that Daniel also put on his uh, um, the sort of system thinking issues and design thinking is about that. And one of the things that is important now is that we have been investing quite a lot in the more specialized part of the healthcare system. At least that goes for a number of countries that have built new hospitals, invested quite a lot in specialized treatments, but now increasingly realize that they have to invest in more primary care and healthcare services that are closer to the need of people, not only physically, potentially by having digital or other types of long range systems to reach healthcare and to get the healthcare to people also in rural areas and sort of around. But I think this calls for new kind of strategy. We've been talking much about structure of healthcare systems and the way that we can optimize by having new structures, new ways of organizing, new ways of providing steering instruments like reimbursement systems and so on. But in a sense, I think we need to go back one step back and say we need essentially to have a new strategy, a strategy that clarifies how we can approach the increasing inequality, the increased demand for healthcare, and the gap that Daniel showed so on his slides. I think this raises and sort of a potential to think more about the issues about leadership, culture, but also cross-sectoral partnerships in order to increase the capacity, but also the range and the collaboration across institutions that need to work together to approach some of these issues. I think there's a huge burning platform at the moment. And we see that, for example, in the UK, where the healthcare system is really under high pressure, but we also increasingly see this in other countries. And I think transformation delayed is sort of sustainability denied. And we have to work fast now to address the gap that Daniel showed so on his slides. So I think that will be my introduction for now, and hopefully can come back to some of these issues.
Thank you. That leads us, of course, in a way to Norway, Dina.
Yeah, thank you. And thank you, Daniel and Mickael, for excellent introductions. My take on this is also to address some of the complex problems and the burning platforms that was painted out by Daniel and Mickael. And I will not show PowerPoint slides today. I often bring too many, so this time I will just go for a manuscript. And I think that my key point is that the demand for healthcare cannot be solved by the health sector. So future health depends on our ability to redesign systems for belonging, purpose, and shared flourishing that address also the needs for current and future generations. And to do that, we must work at the right depth with the right anchors and including a renewed and empowered health sector that enables whole system change. So in this first round, I want to focus on the essential goals and leverage points for transforming health systems and societies to support future well-being. And to do that, we need to think deeply about where we intervene in systems, not only what we do. So my first point in this first round is to focus on deep leverage for lasting impacts. The theory and research on complexity and systems change has taught us that not all interventions are equal. Changing funding levels or launching new programs can help, but they often produce shallow temporary change, as also Mickael pointed out. To transform systems, we need to shift deeper levels, like the goals of the systems, how institutions understand value, and the mental models that guide decisions. So my second point is about using anchor institutions as system catalysts, because anchor institutions are essential. Anchor institutions are enduring place-based organizations that are embedded in local communities and are unlikely to relocate. For example, these kind of institutions include kindergartens, schools, libraries, health centers, hospitals, and big businesses. And that is institutions that maintain a long-term presence and hold substantial resources and are committed to the well-being of the places that they serve. They are embedded in communities and trusted by people. And these are places where people can experience mattering, that is, to be valued and add values to others and self and society. Just to showcase some examples of what I mean, for example, in the Preston model in the UK, which we also highlighted as a good practice example in the Marmot Review for Norway, illustrates this because hospitals and other healthcare institutions can act as anchor institutions to drive local employment, procurement, and green investments, and also contribute to community wealth building. And by aligning their assets with the needs of disadvantaged local communities, they can help address the social determinants of health and creating lasting socioeconomic impact. And another example is from beyond the health sector in Norway, and also informed by the research that we do at the NTNU Welfare. Kindergartens are increasingly being redesigned as hubs for early intervention and community belonging, not just childcare. They serve as relational infrastructures that build capabilities and connection, supporting the long-term health of family and on family well-being. So accordingly, my third and important point that also Mickael pointed to is that health systems need to go far beyond the health sector. Because if we are to create health as a value, we should look at the whole system. And this is why we need a whole of government and whole of society approach to health and well-being. Because too often the health sector is viewed as a downstream responder, but it has enormous untapped potential as a system catalyst. Health systems can convene cross-sector collaboration, steward data for shared well-being metrics, and they can reorient care delivery toward prevention and co-creation. So we must move away from a transactional logic, focusing on what we can deliver, toward a public value logic, asking what kind of values are we creating and how can we co-create capabilities for health, well-being, meaning, and connected care. So a system designer and researcher Josina Vink and colleagues call this service ecosystems design. It's about transforming not just touch points, but the institutional beliefs, the roles, and the rules that govern them. And the Icelandic and Finnish experiences of advancing a well-being economy show that systems transformation require aligning strategic foresight, intergenerational equity, and cross-sector governance. When well-being becomes the purpose of governance, not just a policy domain, we unlock clearer coherence. So I guess that was my first stepping stones into this discussion and what I wanted to bring in this first round. Thank you.
Well, thank you, Dina. Scaring you potentially a little bit, Daniel and Mickael, I'll add you to the spotlight, of course, so that we can also maybe explore a little bit. Certainly, I wouldn't say that you've been reading the same book. That would be wrong. But it's clear that you've been diving into some of the similar challenges, but with significant variations as well. But between you, I mean, I don't think necessarily that I've thought about the fact about using these institutions as anchors or beacons or lighthouses for transformation, but clearly an interesting idea as well of how to use that. But between you, what are I mean, Daniel, did you get a good answer to whether that trajectory was really backed by science?
I was going to say something else to back up what you just said, because this hasn't been scripted. Dina and Mickael and I have never met before. And it's quite telling that the three of us with a totally diverse background are actually converging towards the same thing. And we need to note, we need to take note of that. I think it's important to say. I was also delighted to hear Dina talk about the anchor organizations, because the communities have those. I noticed it myself. I lived in London during the pandemic, and it was those organizations around the corner that were taking people on rickshaws, all the people around town, that actually stood up and started to provide care. Another example, which I think is relevant, I mentioned austerity. I was working with a service design course at the London School of Communication, and they found out that the librarians have a key function. So people with sexual health problems or with mental health problems don't go and see the doctor; they go to see the library to find a book. So those are the front door for a whole range of potential health issues. So we recognize that and see them as these anchor organizations, and then support and enable them. You know, that's a huge recognition, a huge step towards changing healthcare. Sorry, that's the first reaction that I wanted to give on this.
Clearly, the library would be one of those anchor institutions for sure.
Yeah,
But
absolutely.
would that mean, Dina, that when people go to Dr. Google, that's actually more or less the same?
No, I think, what's really interesting about this anchor institutions thinking is that it's very place-based. Of course, we can also have digital spaces and places where we can, seek support and support each other. But I think what's really important about these spaces and places working as institutions is that people come there for a reason, and the reason is not only health. It's about having a common thread to come around and to meet people. So, for example, much of my research has been around using kindergartens as anchor institutions, and families and children, parents, they come there for a reason. They have children there. They have common concerns about the health and well-being of their collective children, and also their own, of course. And that gives like a really impactful potential to rethink the purpose of what we do. So when we look at health as a value and well-being as a value, and not as in terms of sector and like what we do, that can create momentum for many stakeholders and actors and professionals to getting on board and getting involved and co-creating solutions together, and also to rethink how we can do things. And if I can mention just one more example, is also, I think it's really interesting. In Norway, we have this project going on right now where the postal office in Norway, they have a radical innovation projects where because these are also institutionalized practices that reach out to people and have like universal access to people. So they're post officials, and inspired by a innovation program in Finland. They go out and meet people over a certain age, and just to connect them with the community and to services, and to look like, how are you, and having these conversations, and also to find out what are you engaged in, what do you want to contribute to. These are kind of like organizational options for you, and these are the services we have in our local area and community, and work as boundary spanners between systems and actors. And I think in order to have a sustainable health system, and talking about the whole system, not only the health sector, we need to rethink solutions like that. So that's for me now. Thanks.
And it's an interesting perspective. I think, Mickael, if we were to ask the Danish postal offices to do anything, it would be a short day.
Yeah, that's true,
There's
because
not many
there's
left.
no postal offices left anymore. So, but I think one of other type of institutions that we now recently become aware of is that 20% of the population in Denmark lives in social housing communities. And what we realize is that the people who are employed as service workers to do the plumbing, do the repairs of housing, and do practical things for those who live in these houses, they actually spend 1/3 of their time on advising people on social matters. And this sort of the social housing community is now realizing that, in a sense, they play a crucial role for not only people's social well-being, but also potentially for their health, because they are in very close contact with people, and the people who live in these social housing communities are utilizing healthcare systems twice or third as many times as the sort of average population, obviously because of the social gradient for the people living in social housing communities. But in a sense, these service employees are working in these areas. They're very close to them. They can even see when things are going wrong. And they may play a crucial role for being the bridge builder to the healthcare services or community institutions if they know how to. And as one also point that Dina is talking about, the mental sort of models that they have also take account of not only the morn that has to be lowered, or the morning, the plumbing or whatever, but that they also have to be aware of the health issues of the population living in these houses. And we see now projects and alliances popping up, actually focusing on these matters and trying to build partnerships.
Fascinating. But thinking of that clearly there's a lot of potential for innovative ways of using existing structures to overcome some of those barriers. Still, there seems to be barriers of various kinds. And if I allow me to ask you first, Dina, some of I mean, this is a wonderful innovation, perhaps with the Postal Service, and yet it's a story among a lot of non-innovations, if you will. So clearly there's some of those barriers that we see both within the existing health care institutions and also other institutions. And what are some of those essential pitfalls that we see in that transformation? How do we tend not to see maybe an avalanche of transformation, but maybe just continued small snowballs that seem to melt in the summer sun?
Yeah, it's a great question. And I think, just to pinpoint that, because when we talk about systems change, often what we do is we look at our practices, we look at our structures, and we look at our economic priorities, right? But systems thinking, it reminds us that what holds problem in place often lies beneath the surface of these tangible elements of the system. So and it is in the relationships, the power dynamics, the mental models, like how we think about what we're creating and how we can create it together. For example, thinking about health and well-being as values, not as sectors and tasks to be solved. So in this round, I just wanted to start off by reflecting on 3 common pitfalls that we face in transformation efforts, and how to avoid them by understanding the deeper systems dynamic at play. So first, the first pitfall I want to highlight is that we individualize complex problems. So if we treat mental health, obesity, or loneliness as individual failures, we miss the structural forces involved and also the relational forces involved. So we need to shift the narratives and policies to see health as emerging from environments, relationships, and justice, and not only looking at it as something that we should solve within the walls of the health sector. And I think the second pitfall I want to highlight is about participation. And it's about participation without power. Because if we are to change systems, and if we are to take relationships and mental models seriously, we need to involve people, and we need to have these sense-making processes that makes people like feel that they matter and that they have an agency, and that we can co-create both meaning and solutions together. And we risk reinforcing inequity when we invite communities to the table but don't share decision-making. So deep systems change only gain traction when relevant and affected groups feel that they matter and are given real influence and not just being consulted. So we need to rethink how we think about democratic participation also in shaping systems. And the third pitfall I wanted to address is the fragmentation and short-termism that really are very present in the systems that we have. So many well-meaning projects, they fail because they operate in silos. They are tied to short-term funding or like short-term policy cycles and political cycles, like a voting period or something. So we are restricted with and bound within the systems that we are currently in order to have long-term thinking and long-term change. So for example, in Norway, we have municipalities that have run really successful pilot programs on inclusion that never scaled because they weren't embedded in core strategies and budgets within the local systems, and also restricted by the national government and the fragmentation on the state level. So the lesson learned from this, I think, is that we need to institutionalize cross-sector goals and shared indicator sets and have long-term investment plans and really shape systems in line with valuing health and well-being as overarching public values and not as sector-oriented goals. For example, like the well-being economy governments has tried to do and partly really been successful in doing. So, and then you asked us how to avoid these pitfalls, and I don't have the complete answer, but I might have some stepping stones. So I think the first thing is to really dive into that, to try to understand what's going on. We need to understand the system. We need to map the system conditions. We need to look at our policies, the practices, the resource flows, and the relationships and the power dynamics and the mental models, and we need to look at them in combination. And we need to understand the links between system elements in order to change something about it. And in order to do that, we also need to listen to and learn from relevant and affected groups and proportionately invite and pay attention to those who are the most affected by health problems and disadvantage. And then we need, as I addressed in my first point, we need to build backbone structure with the legitimacy and capacity to facilitate participatory processes and coordinate actors over time, such as using anchor institutions. So anchoring transformation in trusted institutions like schools, libraries, councils, and hospitals. And we need to support these actors and institutions to lead with purpose and in combination. And finally, then, we must empower the health sector to act as a convener and system integrator across sectors, settings, and actors. Because to truly transform health systems, and then I'm not talking about the health sector, I'm talking about the whole of society as a health system, we must design not just better treatment, programs, and services, but better systems of trust, accountability, and care across the whole of society. That's from me in this round. Thanks.
Better systems for trust. Yes, for sure. That was a powerful, both run through some pitfalls, but certainly also some solutions for sure, Dina. But Daniel, I mean, we didn't script the first round, and of course now you've listened to Dina, so that's kind of cheating, but I suppose you may have some ideas. You have some slides maybe.
But this is also going to be one of those frustrating events where there's so much perspectives and so on that, you know, because one thing I was going to say, and we might have to discuss it later on, is the education system for health professionals is not fit for any purpose either. You know, 40 years ago, I had to draw every single bone in the human body, which is fascinating, but Leonardo da Vinci did that a lot better before me. I was not taught about communities. I was not taught about social cohesion, and that hasn't changed. And we need to talk about this. So that's one of the pitfalls I didn't have on my list, but it's certainly something that comes out of this and we need to discuss. So this is pitfall number one, and I've been almost a therapy writing up on Substack about things, and I was very, very close to this. So this is the trap that Mickael already said, that you can tinker, that you can optimize the current system. Well, you can't. So the NHS relied on lean, and as you probably know, lean came from the automotive sector, and they decided, oh, lean is the best thing, and we're going to use lean for managing our supply chain. Well, we know what happened during COVID. The NHS workers could not get PPE because lean is about just-in-time procurement. So the fact that the NHS decided to use a car manufacturing system thinking, for whatever reason, on healthcare actually killed the very workers that we rely on. So do not be fooled by improvement. It doesn't do anything. To make matters worse, it can even kill your workforce, as we have evidence of. So don't think you can improve it. Second of all, Nina talked about it. We talked about it before. Is this trust? So I'll skip this, but we probably need to go in much more detail. What I want to suggest is how we at EHFF are thinking about this. So I talked about the banking crisis 2008. There's a famous white paper by a very mysterious person, Satoshi Nakamoto, who actually said we cannot rely on a banking system that we actually cannot trust. And he came up with this notion of a chain of blocks, which led, by the way, to Bitcoin. But I don't want to talk Bitcoin. That's not the point. The point is that there is a technology solution that was then picked up in, I think, 2014 by the guys behind Ethereum and the Ethereum chain to say we can actually build something using blockchain that avoids the trust, but by being able to avoid trust, actually builds trust in. And what we're playing with in EHFF now, playing is the wrong metaphor, to say there's a fundamental issue of trust, there's a fundamental need of information, there's a fundamental need of sharing, and so on. Can we build a DAO, a decentralized, autonomous organization with blockchain technology to really deal with the challenges that we all see and agree on in healthcare? And that's my contribution.
Thank you.
I will try and stop sharing. That worked.
At least we saw or got a hint, Daniel, that there's also a recipe for success. That's good, hopeful. But Mickael,
Yeah,
some-
so adding to, I think, the very good points that Dina and Daniel already have been talking about, I think one of the pitfalls is that and that relates to Daniel's point about lean, is that we have a success trap of incrementalism, that we think that we can build on what we've had of success from the past and then build on from that, and sort of increasingly just optimize and also optimize in silos, as Dina been talking about. I think that's a sort of a common pitfall, and it's kind of a pitfall that is also very tough to avoid, in a sense. Who is actually making systems optimization and more sort of broadly thinking about systems design? I think that's a kind of a pitfall, which means that you either have to think about in terms of sort of an ecosystem, or have some central director that actually needs to sort of order a more comprehensive rather than incremental change to the healthcare system. So I think that's a kind of a pitfall. Also, I think a second pitfall is that the cultural and mindset changes that is needed for a sort of a transformation is not something that is just coming from having the this idea of the burning platform or something else. I mean, it's that, but it is a crucial pitfall that we don't address the sort of more cultural and mindset changes that is needed. Danny have been talking about it, that we also need to address how we train healthcare professionals. I mean, we train healthcare professionals as we did, I mean, back in history. And what we train them for is train them to respond reactively to healthcare systems and respond by giving healthcare services. So no wonder that that's what they still are doing, because that's what they've been trained for, and that's how the professions are thinking. So we have to address these more cultural and mindset changes. Also, I think one thing that hasn't been addressed is the sort of political ownership of this. I think that this is a transformation that requires politicians and the political system to address this, but also to have ownership of how we are going to address some of these challenges, but also the need for changes, but also that these need for changes will be more radical changes rather than sort of these small optimizations things that we have been doing for many years. And fourthly, I think we need to work with our leaders, because they're the ones who have to make these behavioral changes. But what they and Dina been talking about it, that we have too narrow measures, and that also goes for leaders. I mean, how are they promoted? How are they rewarded? How are they recognized? That's by optimizing whatever they are leader for, and they are leader for a department. And what they are measured by is the department measures that they have, not how they contribute to a system, which means that we have to have more strategic measures that are not going beyond these department measures. And we haven't been doing much of that, but increasingly start to realize that that's what we need to do to make these behavioral changes for leaders, but also make them then make these behavioral changes in their departments. So a number of pitfalls that I think we need to address.
Thank you. We have a question from the audience also. If I can pursue, you are not muted, so John.
Hi. Yeah, to listen to me. Yeah, listen to me. Yeah. Okay, I'm a pleasure to be with you. I'm very happy to meet Daniel and David. We are all friends for a long time. No, we are a rock rock singers still making music. Anyway, very short. I agree totally with you. I could agree more. I am from Barcelona. I'm working in Catalonia. I am working with different areas of innovation, and I create a new structure, is InnoHealth Academy. Anyway, and we are working on we need a new model. It's not only to change the way we're working, we need to. Not a model to change overnight is impossible. That means not possible. But how healthcare in European countries could be in 2050, taking into account the tsunami of technologies, artificial intelligence, digital management, health management. I mean, it's a huge amount of things coming up. The system is, at least in Spain, in Catalonia, is saying, okay, yeah, yes, but nothing happens. But that is, anyway, the only thing is the message saying, okay, with you, I agree, will agree more. The thing is, we need to define a new model. The model is from the 30s, 40s, 50s, the same. Healthcare, hospitals, primary care. But what is the prevention? What is the patient longevity for the patient? I mean, there's a lot of things to do. Anyway, I don't want to talk more. It's not my place to talk, but it's only to be, I'm very happy to be with you. And please, we have to talk about InnoHealth Academy and you. I sent to David, I think, what you're doing. We had a last year symposium on the future health, and it's one more. It's not, we don't pretend to be the discovering the world, but to share with you and to discuss and perhaps work together to reach a new model. Thank you.
Thank you. And clearly, of course, with a good case, this is not a discussion for sure from only a Dane, a Norwegian, and a Dutchman, but one that encompasses all of Europe. And given, though, these cases that there's a clear potential and there's some known challenges before us. So let me ask you, I mean, how maybe from your perspective, can we, and the question we just got, well, we got another question too, as well from Alish, but maybe we'll get Alish's question then also to add before we conclude. Alish,
Thank you,
please.
Lars. Look, Dina, Daniel, and Mickael, they all laid out the cards exactly as we understand. We need the change of behavior of the society, essentially, which means deviating from models that I've witnessed in the socialist era that was communism. So that's why where something comes to communal affairs, like Dina said, it might work in Norway. It doesn't work that well in the environment in Czech because we've tried this commune approach. At the same time, we see failure of the market economy approach. So essentially, it boils down in me to the question of how can we cultivate the social intelligence of a population in order to accept the well-being economy, and by accepting the well-being economy, then pushing the healthcare system into the major changes that you've talked about rather than the piecemeal thing that is happening. And my question actually is, do any of you have a historical model when a small community of, let's say, privileged people who don't have to grow their own potatoes and cabbage are able to think about these things, but then how to get this message so that it's accepted by the majority population? So the question is, what models do you see in social intelligence cultivation, and how quickly can that be done if cultivation is a thing that takes time?
Thank you, Alish. Clearly, probably not a matter of artificial intelligence, for sure. Two comments, and also a question from my side. If you were to advise, well, our audience today, but also maybe the wider audience that should be listening today on some avenues that brings us forward from where we are, what would that be if you had 3 wishes for the genie? And I'll allow you, Mickael, to start.
Yeah, so thank you very much. I don't think there's any quick fix solutions or anything that you sort of can, but I mean, from a starting point, I think that changing mindset and purposes will be the most important part. And when I say that, that is to say, I mean, why are we going to transform? And that you have to convince politicians, population, professions, and so on to change their mindset and essentially redirect their sense of purpose into this. And I think that's an important part to start. And for me, for example, you have to start with professions. If you cannot convince them that not just going down the route of subspecialization, optimizing whatever is happening within their medical specialty is the most important thing that we can do, but that they have to think more broader, I don't think we're going to change, because these are strong professions and they have to have this sense of a new mindset rather than just having the sense of whatever subspecialization they can think of. So I think that's a starting point. I don't think that that's a very specific solution, but it certainly is something that is needed to be done. Secondly, I think we need to increase the sort of capacity to think about systems awareness, and that you have to have people, and Daniel said it, I mean, medical doctors are not trained to think about medical systems. They're trained to think about medical symptoms and treatment, but very few of them at least have a sense of the system. And I think that's something that we need to do, that's increasing system awareness, but also the dynamics between the different actors are important. And that goes beyond, of course, the healthcare sector, but also the institutions that matter to either as a collaborator or those who actually influence healthcare or health for the population in general. And thirdly and lastly, I think that sort of designing for long-term resilience is a thing that we need to address. Rather than fixing systems as it is now, we have to design much more for long-term resilience rather than just optimizing. So not very specific and not very quick fix things, but essential things that we need to address.
Yeah, some 3 good points to begin with, for sure, Mickael. And Dina, 3 wishes for the genie.
3 wishes for
And I'm not the genie, but
okay. Well, if I were to wish, I think I would similar wishes that Mickael also posed. I guess it's about purpose-driven systems change. That's the first, and I think that's probably the most important one. To shift the goals and mental models of the system, and to think about health more as a value than a sector. And also to increase the ownership and also the legitimacy and accountability and health literacy across all actors involved, including those most in power, like political leaders and political systems. They need to understand in order to transform, and we need to increase the capacity to dive into the complexity and not push it away. So that's also about rewire goals and narrative, because what is being measured and where the incentives are there, that's also what's being done. So to rethink what we measure and what we value, I think that's really important. And the second one is also, it points back to what I talked about earlier, to elevate anchor institutions and platforms for cooperation. It can be found within the healthcare sector, but also in other places that are really vital for health, and probably more vital for health across the lifespan than the health sector. So, and I think it's also really important as a third point and a third wish for the genie to increase the capacity and design for learning and not just training. And because systems change is not a one-off initiative, it's really a long-term process of adaptive and relational learning. So we need to rethink education and training, as was also pointed to by Daniel before. And we need to co-create learning ecosystems that link reflections and experimentation and capacity building to real-world challenges and future-forming practices and long-term policy making. So we make sure that also future generations has the possibility to flourish within a sustainable system. Yeah, so that's the wishes for the genie, I guess.
thank you. So Daniel, you're the last one today to get 3 wishes from the genie. So what would that be?
I'm going to share a PowerPoint again, and I'm also going to admit that I'm going to cheat. So I hope you don't mind, because I've added a slide. So I'm going to stick to 3, but I'm going to combine these 2. So we already mentioned it. We need to build new organization models, basically, and these organizational models need to be really addressing this trust gap. So that's really one for the genie. The second one, I pulled this slide up just now because I got stuck with this before, and David knows when. But this is one of the definitive models of design thinking. Okay, so what it's saying is design thinking is a divergent process. You discover, then you define, and then you got a pretty good idea what needs to be done. You develop and deliver. Now think about what we do as medics. We do exactly the same thing. A patient walks through our door, we have no idea what's going on. So we actually use a divergent process to really talk to them, find out, do some tests and so on, and a convergent process. The realization that actually design thinking is exactly the same as clinical thinking opens up the door to a whole workforce that can be the penny can drop there as well, to move their ability to think in symptoms and root causes, not just to patients, but to the very organization that they work for too. So if the genie could help to embed or the realization that the clinical processes are design processes, and you can apply therefore these design process not just on patients but on the organizations too, that would be fantastic. And this is the last thing. This is something that Mickael, and as I said before, we haven't said before, what we think we're trying to propose for EHFF is to see a director's role, because I think what we're going towards is a lot of grassroots movements, not top-down movements, grassroots movements. But the challenge for these grassroots movements to have enduring impact is coordination. And what we see is that there is a role there, maybe for EHFF, maybe for another organization, to have a broad overview, not just of what's going on, but also have the theoretical knowledge to then support these initiatives. So that would be the third wish for the genie, to recognize there is a coordinating, directing, controlling, whatever you want to call it, role that is missing, and recognizing that, and how do we fill that? And the last slide is really a plug. You know, if you like what you're hearing about EHFF, please join, please contribute, please jam with us on this. It's important for all of us. I'll stop sharing that.
Thank you so much. Obviously, in 2025, we live in a day and age where some believe that you don't really need air traffic controllers for anything,
Yeah.
at least in some areas of the world. But it was really a pleasure to hear all of your perspectives and insights. It's clear, especially considering that we're over time, that there's energy for even more. So hopefully we will be able to continue this discussion either in another webinar, in another format very soon. But thank you so much for sharing. It was a pleasure. And of course, we'll be hoping to share not just the slides and the recording, but also other good tips and points from the chat that we had today. There was a few there, and also from our good speakers today. Thank you so much.